Hello friends, I am Professor Smita Jha from the Department of Humanities and Social Sciences. Well, I'm doing health, humanities, and disability, and under this caption, we are discussing semiotic mediation of activity. We have already discussed in detail about the semiotic understanding of health humanities. Let us see some of the ethical aspects of medical humanities. The ethical aspect of medical humanities shifts the focus from abstract bioethical principles like autonomy or justice to relational and narrative ethics, prioritizing the lived experience of the patient over technical data. It argues that clinical competence is inseparable from the ethical ability to interpret science and stories accurately. Coming to the narrative ethics and witnessing, in medical humanities, ethics is not just about following rules, it is about witnessing. So, narrative humility, rather than assuming they know the patient a story after a 15 minutes consult, ethical practitioners practice humility, acknowledging that a patient's life context is complex and potentially unreachable. The ethical act of listening, so listening is viewed as a primary medical action. Failing to listen to a patient's narrative is seen as an ethical failure that can lead to epistemic injustice, where a patient's self-knowledge is ignored in favor of objective data. So, semioethic, the ethics of sign, well, this branch of ethics pioneered by a scholar like Sushan Petrilli looks at the responsibility humans have within the semiosphere, the world of meaning. First is responsibility for the other. Semioethics posits that as semiotic beings, we have an absolute responsibility towards the other, the patient. The power of the level. Every diagnosis is an ethical act. Labeling a person schizophrenic or obese is not just a biological description, it is a semiotic intervention that can stigmatize, alienate, or strip an individual of their agency. So, addressing the nocebo effect and communication, the ethical challenge of informed consent is a central topic. The first is the communication paradox. How does a doctor disclose risk without creating a nocebo effect? Ethical medical humanities explores positive framing as a way to fulfill the legal duty of disclosure while fulfilling the ethical duty to do no harm. Premium non nocere. Empathetic literacy, ethics in the field is often taught as literary training. By reading fiction, medical students develop empathic imagination, allowing them to ethically navigate gray areas where clinical guideline provides no clear answer. Social justice and advocacy. The humanities bring an ethical focus to the social determinants of health. Challenging the gaze, it critiques the medical gaze that dehumanizes patients by reducing them to organs or symptoms. Equity in semiotic. It investigates how cultural science like race, gender, class affect the quality of care, arguing that an ethical healthcare system must decode and dismantle its own internal biases. Narrative ethics and witnessing is a framework that prioritizes the patient's life story as the primary site of moral meaning, moving beyond the checklist approach of traditional bioethics. It views clinician not as a detached judge but as an active participant who must bear witness to the patient's suffering. Narrative ethics and the moral power of a story. Now, in this model, an action is judged as ethical if it honors the patient's unique life trajectory. Narrative competence. This is the ability to acknowledge, absorb, interpret, and be moved by the stories of illness. Without this, a doctor may solve a medical puzzle, fail the human being. Second is the good story. Ethics here is about coherence. Practitioners help patients reauthor their lives when a diagnosis like cancer or chronic pain threatens to shatter their sense of self. The act of witnessing. Witnessing is a specialized form of semiotic mediation where the practitioner validates the patient's internal reality. Bearing witness, this goes beyond observing. To witness is to confirm that the patient pain is real and meaningful, especially when medical tests come back normal. Moral recognition. For many patients, the greatest harm is epistemic injustice, feeling that their story is not believed. Witnessing restores the patient's status as a knower of their own body. So, narrative humility speaks of the proposed by Melanie Trevelyan and Jean Moret Gracia. This is the ethical practice of acknowledging that we can never fully know another person's experience. There are several elements of this practice, including against mastery. Unlike cultural competence, which suggests you can master a patient's background, narrative humility requires the clinician to remain open, curious, and aware of their own biases. The ethical space, it creates a between space where the doctor and patient co-construct a treatment plan that fits the patient's values, not just the clinical guideline. So, witnessing as clinical action in health humanity, witnessing is considered a therapeutic intervention. In palliative or end of life care, where a cure is no longer the goal, the act of witnessing the patient's legacy and suffering becomes the primary medical action. So, responsibility for the other in semioethic, being a sign maker inherently means being responsible. Some components of this responsibility encompass the boundless other. Drawing from philosopher Emmanuel Levinas's Semioethics posits that we have an infinite responsibility towards other. In health, this means the clinician's primary duty is not just to fix a biological machine, but to answer the ethical call of the patient's presence. Second is the listening as ethics. It redefines listening as a disinterested act where you prioritize the patient's meaning over your own clinical categories. So, critique of medical level. Semioethic is highly critical of how medical language acts as a semiotic instrument of power. So, the first is the violence of the level. A diagnosis like terminal, diabetic, or schizophrenic is seen as a semiotic act that can reduce a whole person to a single biological science. De-leveling. Semioethic encourages detachment from these levels to see the unique, non-exchangeable human being behind the chart. Global bioethics and the semiosphere. Semioethic expands the scope of medical ethics to include the environment and non-human life. So, health of the semiosphere, it argues that we cannot have healthy human in a sick semiosphere. Environmental pollution or the extension of a species are viewed as semiocide, the destruction of the very science and communication system that sustain life. Interconnectedness. Because humans are the only species that reflect on sign processes, we have a unique semiotic responsibility to protect the symbiotic relationship between all living things, endosymbiosis. Application in health humanities of these tenets. So, in practice, semioethic encourages a listening-based medical model. It moves practitioners away from a will to master the patient and toward a will to care, where the ultimate goal is to maintain the dignity and otherness of the patient throughout their treatment. Responsibility for the other in medical humanities is an ethical framework that prioritizes the clinician's unconditional obligation to respond to the patient's presence and vulnerability before applying abstract rules or technical procedures. Rooted in the philosophy of Emmanuel Levinas and expanded by the Sushan Petrelli's concept of semioethic, it treats the patient not as a medical object but as a unique subject whose face issues an ethical command. Coming to the face-to-face encounter, and according to Levinas, ethics begins when one person encounters another's face. Irreducibility, the other cannot be reduced to a diagnosis, a set of symptoms, or an entry in a database. The ethical injunctions, the mere presence of a suffering person, their vulnerability is a call that orders and ordains the observer to serve them. Ethically, the caregivers and the doctors are bound to do their best to serve and aid the vulnerable individual. Priority of responsibility. This responsibility is prior to knowledge. You are ethically bound to the patient before you even begin the diagnostic process. Under their obligation of responsibility, the caregivers and doctors, additionally bound by Hippocratic oath, are supposed to listen, understand, and help the individual who has approached them. So, semioethic, the responsibility of sign, Sushan Petrilli's semioethic applies these ideas to the way we use language and medical science. Some of these ways, which have also been mentioned earlier, include listening as ethics. Semioethic redefines listening as the primary ethical act, requiring clinicians to listen attentively to the patient unique experience rather than just categorizing their symptoms. Critique of labels. It warns against the violence of labeling, where a medical terms like schizophrenic can obscure a patient's humanity and strip them of their agency. Third is responsibility for all life. Semioethic extends this responsibility beyond the individual patient to the health of the entire global web of life, the semiosphere, linking medical ethics to environment and social justice. Coming to the key concepts in practice, the first is asymmetry of the encounter. Unlike a business contract, the clinical relationship is natural, unequal, because the patient is vulnerable. Responsibility for the other requires the more powerful party, the clinician, to prioritize the patient's needs without expecting reciprocity. Second is hospitality versus mastery. The ethical goal is to welcome the patient's suffering rather than seeking to master it through technical intervention alone. Epistemic justice. Practitioners have an ethical duty to believe and validate a patient's own report of their pain and life experience. So when we talk of implementation in clinical care, so in modern medicine, this framework manifests through four specific steps. The first is ethical awakening, recognizing the patient's vulnerability and radical otherness. Pact of care. This refers to building a relationship based on trust and hospitality rather than just roles and going beyond professional boundaries to help the patient. Technical competence, this include performing the necessary medical intervention as an extension of that care. Caregivers and doctors must have the necessary knowledge and technical expertise to treat the patient and their specific ailment. Fourth is practical wisdom. This refers to using ethical judgment to decide on the best possible good for that specific individual. Different patients may require different medical interventions even if their illness are similar on the surface. It is therefore up to the caregivers to decide practically the most optimum methods and course of action. Coming to the literary imagination in medical humanities, well, literary imagination in medical humanity is the cultivated ability to look beyond a clinical chart and mentally inhabit the possible world of a patient's suffering. It is a rigorous skill, often trained through the close reading of fiction, poetry, and memoir, that allows a clinician to translate a biological diagnosis into a human meaning. While developing narrative competence rather than viewing stories as entertainment, the medical humanity treats literature as a laboratory for the semiotic mediation of activity. Some ways to develop narrative competence, which have also been mentioned elsewhere in this course, include perspective taking. Reading literature forces the reader to inhabit a viewpoint other than their own. In a clinical setting, this helps a doctor imagine the other's life, the stairs they can no longer climb, the isolation of their house, or the fear of their future, which is a blood test cannot reveal. Tolerance for ambiguity. Unlike medical textbook which seek the answer, literature is often ambiguous. This trains the imagination to sit with the gray areas of illness where there is no cure, preventing the clinician from prematurely closing their mind to a patient's complex reality. So, witnessing through the poetic versus the clinical, the literary imagination acts as a bridge between two types of sign. The clinical gaze views the patient as a case of symptom. Second is the literary gaze witnesses the patient as a character with a history and a future. By imagining the patient story, the clinician moves from observing data collection to witnessing, recognizing the moral weight of the suffering. Coming to the empathic accuracy, research suggests that literary training improves empathetic accuracy, the ability to correctly identify what another person is feeling. Some ways in which developing empathic accuracy aids individuals are detecting subtext. Literature teaches readers to notice what is not being said, silence, metaphors, body language. An ethically trained, imaginative doctor can read between the lines of a patient's stoicism to find the underlying distress. Second is counteracting bias by intentionally reading stories from marginalized or unfamiliar background. Clinicians use their imagination to dismantle their own internal stereotype, ensuring a more just and ethical responsibility for the other. Practical training for empathetic accuracy, close reading in narrative medicine programs like those at Columbia University, students perform close reading of text. In practice, these skills. First is observation. Nothing specific words and metaphors used to describe pain. Analysis. Understanding how the structure of the story reflects the chaos of illness. Third is creative reflection, writing parallel charts, personal imaginative accounts of their encounter with patient to process the emotional and ethical weight of witnessing. So, decoding a patient's pain metaphor into an ethical medical action is a standard practice in narrative medicine that transforms subjective suffering into a precise patient centered treatment plan. Now, this process works by identifying the source domain of a metaphor, the concrete image like a stabbing knife, and using it to uncover the specific clinical need or ethical priority of the patient. The ethical logic of decoding is first the epistemic justice. By taking metaphor seriously, clinician validates that the patient's internal experience is certain, countering the ethical risk of dismissing what cannot be seen on a scan. Second is preventing semiocide. Avoiding mechanical metaphors like bone on bone prevents nocebo effects, where threatening language causes patients to stop moving out of fear. Shared decision making. Successful decoding creates a common ground between the provider's medical knowledge and the patient's lived reality, ensuring the treatment plan aligns with the patient's values. So, coming to the practical steps of clinician for decoding sign, first is metaphor elicitation. Ask the patient, what does it feel like? Rather than just, how bad is it on a scale of 1 to 10? Through subjective and personal elaboration, a better understanding can be reached. Close reading identify the specific attributes, color, temperature, or texture of the metaphor to understand the patient's perception of danger. Analyzing the details minutely can help in uncovering the underlying fears and anxieties of the patient. Co-construction, so that propose a new constructive metaphor, an oversensitive alarm system to help the patient reconceptualize chronic pain without feeling their body is broken. So, the case of the locked room is a classic example used in narrative medicine to show how a failed clinical encounter can be rescued by moving from literal diagnosis to metaphorical decoding. The case itself can be understood in three stages. Stage 1, a failed consultation with an uncooperative patient. A 65-year-old man with chronic obstructive pulmonary disease, COPD, repeatedly missed his pulmonary rehab appointments and refused to use his supplemental oxygen in public. So the physician's view, literal or clinical, the doctor saw non-compliance. He repeatedly explained the biological fact: your oxygen saturation is dropping. You are damaging your heart. The result, the patient became defensive and silent. The consultation ended in frustration, with the doctor labeling the patient difficult and the patient feeling unheard. Stage 2, the decoding moment through identifying the metaphor. In a follow-up, instead of lecturing on oxygen level, the clinician used literary imagination and asked, what does it feel like to carry that rank? The patient metaphor, it feels like being tethered to a sinking ship in a locked room. Decoding the signs, tethered, this decoded into a loss of autonomy. The oxygen was not a tool, it was a lease symbolic sign. Sinking ship, this revealed existential terror. He was not just short of breath, he felt his life was inevitably going under. Locked room, this pointed to social isolation. The patient was not lazy, he was ashamed. To him, the oxygen tank was a signifier of invalid status that locked him out of his social world. Stage 3, the saved consultation through ethical medical action. Once the metaphor was decoded, the medical action shifted from coercion to collaboration. Narrative action, the doctor acknowledged the locked room, validating the patient's shame rather than dismissing it. So, reframing the artifact, they discussed portable, discrete oxygen option that looked like a messenger bag. This transformed the semiotic meaning of the device from a tether to a key that could unlock the room. Result, the patient felt his self was seen. With the symbolic barrier of shame removed, his non-compliance vanished and he returned to rehab. Through these stages of empathetically understanding the patient's narrative, engaging with it, and decoding the signs provided by the patient's metaphorical expressions, the clinicians, caregivers, as well as lay people can develop their empathy and communicate better with the patient, leading to a significant improvement in providing health care. With this, I conclude today's lecture. Let us meet in the next lecture with Zoner as the social course of medical humanity. Till then, thank you.